everyone. Thank you to Dr. Muhammad Azuddin and Prof. Iswan for your wonderful presentation. So now I'd like to move on to our second topic. I would like to introduce my colleague, Dr. Harwinder Singh. He's a plastic and reconstructive surgeon in my team, working in the Department of Surgery, PPUM. He obtained his MD from Russia. Subsequently, he is a subspecialist in plastic surgery in USM. He is involved in all our MDT sessions in PPM as well as referral from other hospitals. Today, he will be talking about overview of plastic and reconstructive surgery services in PPUM, a multidisciplinary approach. Please welcome Dr. Harwinder Singh. Thank you.
And good morning, everyone, and thank you for being here with us today on a Wednesday morning to listen to a couple of interesting talks. I hope that mine will be interesting as well as informative for everyone here. My topic today will be the overview of plastic and reconstructive surgery services here in PPUM. How we approach it in terms of multidisciplinary approach. Interesting that the previous speaker spoke about MDT approach, because in today's practices, right, in centers like in tertiary and quaternary centers, I think that multidisciplinary approach to patient care has to be a must, if not had at all times, because there is no other way about it. It is the best. It is shown to have the best outcome in patient care. So I will be talking a little bit about our services here in PPUM, what our unit does here, and also how we collaborate with other teams in terms to MDT approach for our patients. But before I get into more detail about talk, I just want to talk a little bit about the history and how plastic surgery came about. There was a very famous surgeon back in the 1600s by the name of Gaspare Tagliacozzi. He had a very, very interesting quote in most of his literature that he has produced. He has mentioned, "Restore what nature has given and chance has taken away. The main purpose of this procedure is not the restoration of the original beauty for the face, but rather the rehabilitation of the part in question." So plastic surgery is in fact a product of constant innovation and can be traced back from many great civilizations years ago, and is kept on evolving since then, and until today it is still evolving. And it has shown that from all the primitive procedures that was done back in the day, a few hundred years ago, a lot of the procedures are still adapted, improved, and used until today. The word plastic surgery itself comes from a Greek word, which is plastikos or plasein, which means to mold and to give form. It is a specialty that involves restoring, reconstruction, and alteration of the human body. It really depends on a lot of aptitude for forming and shaping, and a lot of artistic skills are required in the discipline, as well as creativity. Because there is no, I might be repeating this phrase throughout the talk, but there is no one size for all in plastic surgery. There is no one procedure that fits for everyone. Every single procedure that we do has to be tailor-made, has to be individualized, and has to be custom-made for a particular patient. So because the field of plastic and reconstructive surgery involves a lot of regions of the body, head to toe, a lot of knowledge in anatomy, gross anatomy, as well as minute anatomical details are needed. So the reason why I chose this particular talk today is because after spending years in this field, we have found that in the random population, the mindset is that plastic surgery is only about aesthetic practices and also about burns management, which is not true. We are trying to educate the public as well as even the healthcare workers themselves, especially the junior ones, that plastic surgery is not just about aesthetic practices and burns management as taught widely. If we categorize plastic surgery, it can be divided into two main categories, which is reconstructive surgery and cosmetic surgery. Reconstructive surgery, the aim is to reconstruct a part of the body or to improve its function, its cosmetic or its aesthetic outcome. whereby cosmetic surgery is to improve your appearance, but reconstructive surgery is to restore what nature or what has been taken away. So under the field of plastic surgery, there are actually a few other subspecialties. These are the main ones that I have listed here, which are burns, hand surgery, general reconstructive surgery, microsurgery, pediatric plastic surgery, craniomaxillofacial oncoplastic, and so forth. Aesthetic plastic surgery is a field on its own, which also involves surgical and non-surgical procedures. So essential feature of plastic surgery is that it involves the treatment of conditions that require a lot of movement of tissue, relocation of tissue. In simple terms, it means that we take one part of the body, one part of tissue from a body, and we replace it in the part that needs it. Of course, this is not done at random. We take parts of the body that is more similar to what is needed. So as what the principle guides us and says, that replace like for like. So it requires skill that is able that makes the surgeon able to move part of the body to another part. And because we deal with a lot of patients that are referred from a host of other disciplines, the MDT approach is, I feel, mandatory, so that we can give the best outcome for patients who have got very complicated medical and surgical problems. So the main bulk of our referrals come from a lot of other surgical disciplines, which I will run through here and to show example of cases that we do together. So I'm briefly going to divide the presentation into scalp reconstruction, head and neck reconstruction, chest wall or thoracic reconstruction, abdominal wall reconstruction, perineum reconstruction, lower limb clefts, and burns. I've put it in such a way so that we can probably briefly go through every single part of the human body and to just show one or two cases that so that the audience have an idea of what reconstructive surgery in a particular body part is. So we will start off by talking about clefts. So cleft lips and palates are, as we know, is quite prevalent in our population. If I'm not mistaken, the number is that 1 in 800 babies are born with clefts. And cleft patients require a multidisciplinary cleft clinic in most hospitals. At least in all the tertiary and quaternary centers, you do require a multidisciplinary cleft clinic. And this involves teams of plastic surgeons, PITS dentists, oromaxillofacial surgeons, audiology, pediatric otolaryngology, speech pathology, occupational and feeding therapy, and also genetics. The care for the cleft patient starts, in fact, when the baby is in the womb, all the way until adulthood. So they involve, they go through countless procedures, many procedures, and they have to go through a lot of therapy throughout their lifetime. So there is no other way about it. Multidisciplinary cleft clinic is obligatory in managing a cleft patient. So the surgery for babies start as young as 1 month old, depending on the situation. In our center, mostly we start at 3 months old, whereby lip repairs are done as the first setting, followed by the cleft palate repair, and then bone grafting, alveolar bone grafting, and finally rhinoplasty and also scar revisions for the patients who have gone into adulthood. So as we can see in one of the examples, the pictures here, in a patient, in a baby with unilateral cleft lip and palate, we do a lip repair as young as 3 to 6 months old, depending on if they are having any other problems. The earlier, the better. And this is an example of another girl with a left unilateral cleft lip and palate. I'm not going to go through the technical details or what kind of methods we use and what kind of surgery is performed. Generally speaking, these are all lip repair surgeries, but there are multiple techniques and multiple types of lip repair. But I'm not going to go into the technical part of it. This is just for education to show the work that we do here in collaboration with other teams. This is again another a child with a left unilateral cleft lip and repair, as seen as before surgery, 3 months after surgery in the center, and 1 year after surgery. She's crying here because she doesn't like her picture taken. And another girl who underwent left-sided lip repair. And again, the child's in tears because they don't like the picture taken. Another child here with the lip repair, as we can see that sometimes in some cases the noses are affected, so in some cases worse than others, in some cases not so bad. Like in this child, the nose was luckily not too bad, the palate was not too wide, the repair was done without any problems. Example of another child. And moving on to another type of spectrum of cases, bilateral cleft lip and palate, as we can see here, presents as a challenge for any surgeon performing cleft surgery or cleft surgeons. So the repair is very tedious and it's very difficult to get actually the outcome that we desire. But of course, we try our best. In some cases, the patient will require further surgeries in the future as they grow up, just to improve and to get better outcomes for them, especially in the aesthetic point of view. Once the lip repair is done, patients have cleft palate, their palates repaired, and this usually occurs at between 9 to 12 months old. As you can see here, this is a child that has got a very wide cleft, and bilateral flaps are raised based on the greater palatine arteries. As you can see here, these are called mucoperiosteal flaps. They are sutured in the center, and once they have healed, the donor site in the lateral part mucosolizes itself, and we have a complete closure and also patency. As children with cleft move into adulthood, the next part of their complaints will usually come to the fact that they're not happy with their nose or with their scar on the lips. We usually reserve to do any kind of revisions once the patient is in their older age, in their teens or in their 20s. For example, this patient came back after probably 20 years. She's in her early 20s, just complaining that she's not happy with the symmetry of her nose, the height of her nose, and the nostril is not shaped well. And she says that she lacks projection in the nasal bridge area here. So she asked is whether we could do any surgery for her, or we could offer anything to improve her appearance. So we subjected her to a rhinoplasty, whereby we harvested a rib cartilage graft, and we carved the graft into multiple structural support. The four main that was used here were the columella strut graft, ala rim graft, tip shield graft, dorsal strut graft. Don't worry too much about the terminologies. This is just to depict that the rib that we use is carved and to use to support the nasal framework in order to improve the aesthetics of the nose. So this is shown in the patient 1 week after surgery, and on the right here is shown 1 month. This is 1 year after surgery. Compared to the first picture, if you can see, the patient had a very flat, very wide nasal base compared to here, which is a bit more narrow. We did a bit of ala reduction for her as well. And we improved the projection of the tip by putting more structural framework to hold the nose up and to give it a bit more definition at the tip, and slight more increase in nasal height here. So this is the depiction of before and the after. As you can see, the differences is very subtle, but at the end, the patient was happy because she wanted the dorsal part of the nose, the nasal bridge here, to be improved slightly higher, and also a little bit more, just a little bit more projection in the tip of her nose. So as you can see, the cleft patients undergo multiple surgeries, starting from lip repairs, palate repairs, and of course, they also undergo alveolar bone grafting for the gums. And finally, they undergo, if needed, rhinoplasty procedures. Some of the complications that happen from cleft patients are palatal fistulas, whereby there is a breakdown, either a full or complete breakdown in the repair, and you get patients whereby they present with a big hole in the anterior part of the palate. So these are unforeseen circumstances in patients. So we do have to anticipate patients will undergo even more surgeries than anticipated. So in this child, because the fistula was causing him a lot of problem, whereby whenever he eats, the food goes through and exits through the nose. There is a communication between the nose and the oral cavity here. So we subjected the patient to another surgery to repair the fistula, whereby we used a tongue flap. So the tongue flap is actually a two-stage procedure, whereby the first stage we repair the nasal layer by turning over the mucosa of the existing palate around the fistula, and then raising a piece of tissue from the tongue in order to close the fistula here. So this piece of tissue that's attached to the fistula will be left in situ for about 2 weeks before the patient goes for a second division. The reason why we stage it is because the fistula needs to, the tongue flap here needs to heal itself and get blood supply from surrounding tissue before we can detach it. So in terms of plastic surgery, there's one principle that everyone adheres to, which is called the reconstructive ladder / the elevator. The initial description about the reconstructive ladder was created, in fact, to guide the surgeon, and how to perform reconstruction. It's not an obligatory or mandatory thing to follow, but it does guide us, whereby a simple wound to a complex wound will require different kind of surgeries to address their problem, starting from the most simple closure to the most complex, which is free tissue transfers. So along this presentation, you will see various kind of techniques that we have used and the services that we have here in University Malaya to showcase to the public that this is the kind of reconstructive work that is done here. So starting back from the head, if you look at scalp reconstruction, we get a lot of referrals from either dermatology, sometimes even neurosurgery or even general surgery for tumors arising in the scalp. And these tumors can be anything from benign to malignant tumors, such as in this case, an elderly gentleman here presented with an angiosarcoma of the scalp. He underwent a wide local resection and a simple skin grafting procedure because he had a host of comorbidities and we didn't want to subject him to a very long surgery. He was already in his 80s at the point when we did surgery. So the idea was to get the tumor out and to cover the scalp as fast as possible and wait for the pathology so that we can subject him to next treatment. This is an example of another patient who had basal cell carcinoma of the scalp, who underwent wide excision and also just a simple skin grafting procedure. This procedure, in fact, if feasible, can be done under local anesthesia if needed. So the patient healed very well after surgery, and seen here 6 months after surgery, the graft has taken very well, and the color match is actually quite good. Another lady presented to us with a squamous cell carcinoma of the scalp. Well, in her case, because she was worried, in fact, about how the surgery will affect the growth of her hair. So instead of doing, and she didn't want to go through multiple procedures, she asked if there's possible to undergo through just one procedure. So we offered her an excision, a wide excision of the tumor, followed by a local transposition flap. This is called a rotational flap, whereby the back of the head this flap is designed at the back of the head, advance into the defect, and then close again primarily. So initially, the patient will of course be bald during the surgery, but as hair grows back again, we can see that aesthetically the outcome is actually quite pleasing. Once the hair becomes longer, the scar is not really visible anymore, and she was a very happy lady at the end. Another case of a child, this boy was also having, in his case, it was just a very large cyst of the head, but it was growing quite substantially in recent times. So we gave him, we performed surgery on him, whereby we excised a large cyst on the head and did a local flap as well. And the key behind doing this kind of surgeries is not to damage hair follicles, because once the hair follicle is damaged, we are not going to get hair growth back in the said area. So moving on to examples of head and neck reconstruction, a lot of referrals come from either the oromaxillofacial teams or from ENT team mainly. And this involve a lot of tumors arising from the oral cavity or from the tongue or from the neck. So like in case of this lady, she had hers was one of the carcinomas of her tongue I can't remember the pathology exactly. So she underwent a hemiglossectomy, and then we reconstructed her tongue using a free tissue transfer technique using tissue from the forearm, whereby a radial forearm flap was raised and transferred into the mouth to reconstruct the hemi tongue. The radial forearm flap is actually based on the radial artery here, as you can see, this little vessel over here. And this is the cephalic vein that was used also to improve drainage of the flap. These vessels were then anastomosed in the neck region to one of the vessels here. So this is again a depiction of using the most simple technique as skin grafting and moving on to very complex techniques for more complex wounds. Another case that was referred by the ENT surgeons here was for larynx carcinoma. So you can see here the patient underwent a laryngectomy procedure, and in order to reconstruct and to restore the continuity of the oral cavity and the stomach, we performed a free colonic flap for this patient. A free colon flap is actually taken from the transverse colon of the patient, and the colon is then brought together with its blood vessels to the neck region and is connected back to the throat to the superior esophagus. And the vessels are then reconnected to one of the vessels in the neck again. So this is one of the procedures that is done actually quite a lot now in our center here to address patients who have got carcinomas of the throat. Another patient that underwent a previous resection with a different surgeon in a different center presented to us with a fistula. So after exploration, we could see that he had a defect here in his pharynx, whereby again we used another colon flap, the transverse colon to be exact, and the flap was opened up, splayed open, and laid to cover the entire area. This patient had radiotherapy before, so the purpose of this was to in fact improve the contracture of the neck as well, and to give him to sort of like give a gliding movement here, and to address the fistula as well. And as I mentioned before, this surgery involved microsurgery, whereby the middle colic artery of the colon was anastomosed to the transverse cervical artery, which is this one here. This is the middle colic artery, and the middle colic vein was anastomosed to the internal jugular vein in the side manner. Another example of head and neck reconstruction that we do here is a mandible reconstruction. This young girl had a resection of her mandible couple of years ago. She had Ewing sarcoma of the mandible. So after the resection was done, patient was disease-free for some time. She came back to us for reconstruction of the mandible. So as you can see in the CT scan here, she's lacking basically from the ramus onwards, there is no more bone and also no more teeth here. So in order to rehabilitate that, we reconstruct the mandible using tissue from the leg. So this is again another free tissue transfer case, whereby we take the fibula bone together with its blood vessels, the skin, and also the muscle, and we actually form it in order to shape according to the mandible shape, and we anastomose the vessels back in the neck region so that the patient can have, first of all, a better aesthetic appearance in terms of the jaw protrusion. And this in the future, once everything has healed, she will undergo dental rehabilitation, whereby dental implants can be placed into the flap itself. Another case again of a patient with a squamous cell carcinoma of the neck underwent resection, and he required 2 flaps, whereby this patient had a mandibulectomy as well. So a fibular bone was used to reconstruct his mandible and a tram flap from the abdomen, as you can see here, taken again with its source vessels, anastomosed in the neck region. Another example of non-tumor cases that we get that require our services would be cases in Perry-Romberg syndrome. Just for information, it's a rare condition that involves a slow breakdown and wasting away of the skin and soft tissue of the face, as we can see in this young lady, whereby the left side of the face is already atrophied and progressively atrophying over the years. So in her case, what we offered her was actually fat transfer, whereby we perform liposuction in areas where there is abundant fat, for example, in the abdomen, in the thighs, and that fat is then processed and is re-injected back into her face or in the area where it's lacking. This might require more than 1 sessions, but at the end, we do we are able to achieve some improvement in volume. Like in her case, her main complaint was the lack of definition of the cheek and lack of volume and asymmetry. So after 3 sessions of fat grafting to the face, we have managed to improve her outcome. This is another case, example of a very young female who had neurofibromatosis of her neck, of her posterior ear. Her main complaint was not so much of the small tumor growing here, but the fact that her ear was malpositioned. It's been dragged down over with the weight over many years. So what we have performed for her, we offered her a debulking of the tumor and incorporating together with a facelift procedure to reposition the nose, to reposition the ear, sorry. And of course, initially the correction is be overcorrected, but as time went by, we can see a subtle improvement in the position of the ear, whereby the ear is no longer sitting where the mouth is, but higher up here where the canthus is. So this is before surgery. This is immediately after suture removal. This is a few months again. So she was happy, especially once her hair grew back. It managed to cover up most of her scars, and she was happy with the position of her ear. This is again a before and after picture. Other cases that we get referrals from dermatology colleagues will be a lot of cutaneous malignancies that involves the face region. So example, we have patients that come with a basal cell carcinoma of the face, whereby they require excisions and also flap closure. In this case, we advance a Mustadi cheek flap for her. And this is an example of another case of a gentleman who underwent a similar kind of procedure. So we avoid two-stage procedures. We prefer to do the resection at the same time advance the flap so that patient can just have one surgery and sort out the problem. Similar case in another patient as well, basal cell carcinoma of the cheek, whereby a cheek rotation flap was used to cover the defect. Another gentleman that came to us with a cutaneous malignancy over his head region was this gentleman who had a sebaceous carcinoma that was not excised entirely because the surgeon was not aware before that. So when the patient's pathology came back and reported as a carcinoma, we had to go in and re-excise the entire scar region. And since it was involving the eyebrows, we decided to use a flap from the head region whereby it could have some kind of hair growth to similarly match the eyebrow. So this is called a temporoparietal facial flap with hair-bearing tissue, whereby the tissue is raised based on the STA, the superficial temporal artery, and is then transposed into the defect, carrying this piece of skin which has a hair on it. So as the patient heals later, it will have hair growing from the tissue, and the patient can undergo then later procedures to equalize or to make it symmetry with the opposite side. So that will be another stage procedure. But the main aim of the surgery was to remove the carcinoma and to get hair-bearing tissue so that the patient wouldn't have alopecia of the eyebrow on this region. Another patient in a similar case came to us. She was a victim of, sadly, an acid attack. And she suffered horrendous burns to her face and to her limbs, to her body, but the most affected area was her face. She probably underwent 20 surgeries at least in a different state, in a different hospital. So when she came to us, at that time, the complaint was she didn't have eyebrow hair at all. So it was very unnatural. She underwent a few procedures for hair transplant, but didn't work out too well for her because the tissue was so heavily scarred. So again, we repeated the procedure whereby we took hair-bearing area from the scalp with the hair follicles and basically moved it into the defect. As you can see here. So once the hair-bearing area from the scalp has been moved into the defect, we can contour it to match the opposite eyebrow and have hair actually growing from the area. And even if the hair growth is not so dense at the moment, at least the main point of the surgery was to bring in tissue from other parts of the body where it's not scarred, and hair transplant can be repeated on this area if needed. Another case of a basal cell carcinoma of the nose, whereby the patient needed excision of the nose and which basically exposed the cartilages of the nose. He underwent a forehead flap, whereby again it's a staged procedure. We bring in tissue from other parts of the body, transpose it to the defect, let it heal, and then detach it once it has healed. And basically from here on is all about scar management. A lot of our patients that referred from the breast and endocrine team are for breast carcinoma patients, whereby they undergo very wide resections. They are left with huge defects in the chest wall. They are referred to us for basically management, either to close the chest wall wound or in fact, in some cases, to reconstruct the entire breast. So we utilize the free tram flap, whereby a tissue from the abdomen is harvested together with the rectus muscle. And this tissue is then transferred up here and re-anastomosed to one of the vessels in the arm or in the neck. And the positive part or the advantages that you get from this kind of surgeries are that the patient actually ends up with an additional tummy tuck, because this is basically giving the patient a tummy tuck. So it's a 2-in-1 procedure. So the defect is then well covered, and the patient can then go for radiotherapy as needed. In some cases, you get recurrences of cases whereby a tram flap was done in the first setting, patient ends up having a recurrence, excision has to be done. This is then we use a tram flap. A tram flap comes, a latissimus dorsi flap. It comes from the back. As we can see, we raise the flap on the back here. Sorry, the picture is not in order. So a flap together with the skin and its muscle is raised on the back and transposed into position. This is another case of a young boy who had a bronchopleural fistula after having recurrent tuberculosis infection. So he ended up having a very scarred lung, and the lung basically collapsed. So as you can see, this is the exact same position the patient is in. We raised the lat dorsi muscle first before continuing with the procedure. After the muscle has been raised, we have to expose the ribs, cut open the ribs, enter the pleural cavity, find the fistula, repair it, and then use the same muscle to patch up the lung. So these are cases that we do get from our colleagues in thoracic surgery or cardiothoracic surgery. These are one of the cases which are the non-cancerous cases. This is like a fistula case. So once the procedure is completed, the ribs are plated back and closure is done again to reconstruct to complete the reconstruction. Another case of a bilateral breast carcinoma patient underwent resection, and we used an anterolateral thigh flap for her here. Again, the flap is raised together with his pedicle, with his arteries and his vessels, anastomosed again in the axilla region as well. Another example of a chest wall reconstruction, whereby we excised the entire tumor and reconstructed the defect with the gracilis flap. The gracilis flap is one of our workhorse flaps that we use here a lot because of its speed and its ease to raise and short operating time. So the gracilis is raised together with its muscle and its skin, brought up here and re-anastomosed. Again, the vessels are re-anastomosed in the axilla. In cases whereby the patients are not candidates for free flap surgery, we can even do pedicle flap surgeries, such as in this patient who underwent a carcinoma resection of the breast. The defect was repaired again with a tram flap. Similar procedure. The only difference is in this case, the flap was not detached from the patient, is pedicled under here to reach the defect, and the closure is done. And this is seen as the patient's results after 1 week and after 3 months. Sometimes we get referrals from our colleagues in the breast endocrine team for breast reconstruction, which are delayed, such as this patient who had a resection done in a different center, in a different hospital, came back after 2 or 3 years at least, complaining that the lack of breast tissue is making it hard because she has to wear a lot of padding in her bra, and she also has a lot of imbalance in her posture because the weight is not equal on both sides. So in her case, she underwent an abdominal wall reconstruction with also a tram flap to equalize and to give her at least some weight in the opposite breast, so that there is some symmetry. And she also was happy with the result, as she could at least get some equal amount of volume. She opted to have a nipple reconstructed after that. So we did just a simple procedure under local anesthesia to reconstruct her nipple. As you can see here, 3 months after surgery, the projection is quite good. Another case of a botched aesthetic surgery whereby the patient's nipple was basically distorted. We repaired that for her. This is another case of gigantomastia whereby the breasts are basically grow out of control. Patient underwent a mastectomy and we had to close the chest wall. In other cases, we do get referrals such as in breast reduction, like in a young patient with very ptotic and heavy breasts was complaining of back pain and she was only 18 years old. And after much counseling with her, we spoke to the parents. She opted to have a breast reduction done. This is her 1 year after the procedure, and she's much happier with the size and able to find a bra that fits, and she has better movement now, able to exercise even better. For male patients, we do offer surgeries for gynecomastia, those who come to us in either via liposuction, such as in this case, or even direct excision, such as in this case. So the patient was not able to afford the liposuction surgery, so we just had to do an excision via the nipple opening. This is another example of a neurofibroma, a patient who could not even wear her pants or her jeans properly because she had a tumor growing here. We resected it for her. Abdominal wall reconstructions are done a lot in our centers as well, together with the colorectal team, who refer to us cases whereby the bowel tumors in fact invade the abdominal wall. And as you can see here, this is a very young gentleman who had a very advanced tumor, which involves the entire abdominal wall. So we had to reconstruct the abdominal wall with flaps taken from the leg. This is called the tensor fascia lata flaps, one from each side. The donor side was then skin grafted. This is a case of another patient who had a hernia repair done. He had an incastrated hernia whereby the hernia was not reducible. So he actually had to have some part of the bowel removed. And again, we use the tensor fascia lata flap, the facial part, to reconstruct the part and to give it strength. And hopefully the repair will be, once and for all. Another case of abdominal wall defect as well, repaired with the tensor fascia lata flap. This is a defect in a young bodybuilder who had trauma, who underwent surgeries before in the past, and he ended up having a hernia as well. So we have utilized the tensor fascia lata flap to reconstruct the defect, to give it strength and to close it. And hopefully he will not have a hernia problem again. Perineal recon cases such as bed sores, we do get referrals from the rehab team as well. So we do perform surgeries for them in order to resect the ulcers or the big, as we call it, the bursas that we have here, reconstruct it with local flaps. This is an example of a sacral sore patient in a paraplegic child who underwent gluteal rotational flaps. Another part of our reconstruction involves patients with extramammary Paget's disease who have to have a wide excision done. And in order to reconstruct the entire perineum, we have to use bilateral gracilis flaps on both the legs to reconstruct the defect. The donor site is then closed primarily. Another case of melanoma of the labia, whereby patient underwent anterior pelvic exenteration as well, in fact. So she had to remove the entire tumor itself, the area where the melanoma was. Part of the rectum, sigmoid colon was removed, the bladder was removed, and the lymph nodes left her with a huge defect in the perineum. And we again utilized the tram flap, whereby the abdominal skin was harvested together with the muscle, transposed and fixed. Another case of a patient who had trauma, degloving injury of the buttocks, and he underwent another flap surgery whereby we took tissue from his thigh and the anterolateral thigh flap. Our perineal recons also involved a lot of patients who have got Fournier's gangrene. So in some cases, the cases are less complex, and we managed to actually use the existing scrotal screen and basically reconstruct the scrotum. So patient is rather happy because from having able to avoid a lot of long surgeries. Some patients come to us with penile siliconomas and referred to us by urologist team because patient is unable to have sexual intercourse, like such as in this patient. The tissue around the penis is scarred, fibrosed, and very hardened. So we had to proceed to deglove the entire penis and reconstruct the penis using scrotal flap, whereby it's a two-stage procedure. The penis is first tunneled into the scrotum. It's again basically borrowing the tissue from the scrotum, and then the ventral part will then be closed with a combination of local flaps. So at the end, once the patient has been healed, and once the patient has healed, he has gliding and softer pliable tissue, which enables him to have sexual intercourse. Another case of Fournier's gangrene reconstructed with a gracilis flap. I'll just run through briefly. I know we're out of time now. Just want to run through a few cases that we do with orthopedics team as well, whereby they refer to us cases like for lower limb reconstruction, such as in this case, a patient had a trauma and scar formation which hindered his movement of his foot. So we had to excise the scar, harvest a flap from his tensor fascia lata as well, and resurface the area with the flap and a skin graft. This is him 1 week after surgery. Another traumatic case whereby the patient lost his third, fourth, and fifth toes. We resurfaced the entire foot with the anterolateral thigh flap. Anastomosis was done with to the dorsalis pedis artery, and this enables him to have some padding to have some footwear. Sarcoma of the knee joint, excised and reconstructed with a tram flap as well. Again, patient who has got gangrene, not Fournier's gangrene, sorry, who has got necrotizing fasciitis of the lower limb, reconstructed with the rectus flap, followed by a skin grafting procedure to resurface the entire limb. Similarly, another patient on the other limb, the rectus flap was brought from the abdomen, anastomosed to the lower limb, and resurfaced with a skin graft. Heel defects are reconstructed with medial plantar artery flaps, as we can see here, because we want to provide the heel with glabrous tissue that is same in nature. So we basically do pedicle flaps for them here, whereby the medial part of the leg here, where is a non-weight bearing part, is transposed and brought into the heel, and the donor side is then closed with a skin graft. Another 5-year-old child who had trauma and a very severe scar contracture of his toe, whereby the contracture was released and a gracilis flap, a free flap was used to reconstruct the defect after we have removed the scar tissue. Synovial sarcoma of the joint that was basically removed together with the quad complex. So we reconstructed the quadriceps with a tensor fascia lata flap and abdominal free flap. Again, a chronic ulcer of the lower limb, requiring a rectus flap and also skin grafting. This is an amputee who had a chronic scar here and who had malignant transformation of the stump of his amputated leg. We had to excise the entire carcinoma of the stump and reconstructed it with another flap here taken from the thigh so that he could continue to wear his prosthesis. Another surgery offered here in PPUM is lymphedema surgeries. Patients that come with us with giant lymphedemas also undergo radical resection, whereby we deglove the entire leg and resurface them with skin grafts. So of course, it's very, very labor-intensive surgery, but sometimes satisfaction is, in fact, overcomes it. Limb reconstruction, aneurysm of the brachial artery, excised, and then the brachial artery is reconstructed with another graft. Trauma of the hand, reconstructed with flaps as well. Squamous cell carcinoma of the arm, reconstructed with radial forearm pedicle flaps. Axillary dissection was done. These cases sometimes are referred to us by the orthopedic team or even from general surgery or even from dermatology who discover patients who have carcinomas. They refer to us for excision and as well as the reconstruction. So as you can see here, the reconstruction is fairly, it's quite good cosmetic outcome. Lastly, we'll talk a little bit about burns. This is a child who had very severe burns at the age of 3. She had to undergo a similar to what I think the most recent news, one of the footballers in Malaysia who had the same acid attack burns, who had allograft applied for him. This is human cadaveric skin, donor skin that is obtained from Belgium to cover the wound. Patient undergo then micrografting because there's not enough donor skin, so we have to actually find methods to expand the skin, and the skin is then transplanted onto the child. And as you can see, this is in the early wound healing phase, and this is probably a few weeks after that. As we can see, the skin starts to mature and epithelize, and we achieve coverage. So just to conclude, plastic surgery is a specialty that is not only about aesthetic practice or burns, as what the random population or other healthcare workers think. It's not a one-man show to deal with complex medical and surgical health problems. So we have to collaborate with all specialties because it is the main key to success and for better outcomes of our patients. I apologize for taking up a lot of your time, but appreciate the attention. Thank you so much.
Thank you, Dr. Harwinder. It was a very comprehensive overview of plastic and reconstructive services in PPUM. As you can see, our division is the most involved in MDT with all other disciplines in the hospital. We are sorry that we don't have time for Q&A, but if anybody has pressing questions, you can try to answer. Looks like there's no Q&A, there's no question. So thank you, Harwinder.
Thank you, Dr. Kong. Thank you, everyone, again. And have a good day.